Go clockwise. Let me show you the way I would do this. Yeah, you were following. So you get to second portion. So I stop in the bulb and I don't push in more. You pushed in, right? I just do small wheel to the right, big wheel towards me, and reduce. Just like you do in normal EGD. It's the same maneuver, it's just a different scope.
Mustafa, we are with you in the room.
So this is a young man with recurring pancreatitis with an inflammatory collection in the tail. So we've done the stomach and the bulb, normal bile duct, normal appearing gallbladder. There is a collection, a lot of inflammation that I can show you towards the end. And we're just going to evaluate the second portion. So I was just showing Dr. Kasser how you basically reduce. I see people when early in their sort of EUS training do a lot with the scope, but all you do is you go in with your scope, get to the bulb, go clockwise, small wheel to the right, big wheel towards you, and not locking the wheels and just pulling back the scope. And that is enough in most cases. Every patient is different, but in most cases for you to now come back to the second portion in a short position. Again, Dr. Hassan's approach and mine are slightly different, but I will look for the papilla first, and once I see it, I'll suction a bit, big wheel towards me, and I know that I should be close. If I'm having a hard time making contact, I'll put my balloon up. And you put the balloon up, and you gently sort of pull back the probe, and you're up against the pancreas. Now you're just going to pull back, and you're going to go counter and clockwise looking for your ducts. We know from this patient's bulb view that the ducts are small, but right away I think I can see the pancreatic duct, which is this one here. And from here, when you go counter, you should get the bile duct, which in him is very small, so we may or may not see it. So in order to see the bile duct, I may have to relax the pressure on my probe, which may make you fall back. This here, this structure here, going in, that's your bile duct getting compressed. If I try and release it, I may see it better, but there's also air artifact. But there, you can see there's a bit of bile duct there. If I go clockwise, there's the PD. So now I'm going to just remove my flow and my cursor out of the way. And I'm just going to follow the pancreas back. There's the PD. And you can see, I can see that small PD coming towards the portal vein, which is this structure here. So one of the goals with EUS is to try and exclude divisum. So as I pull back, the PD becomes very difficult to follow, but it's basically it's this guy here, right there, this thin streak. And if it goes over the portal vein like this, then we know it's not divisum because we followed it all the way from the, there you go. So all the way from the major to the neck of the pancreas. So basically we're left with a guy with recurrent acute pancreatitis, pancreatic inflammatory changes, no obvious gallstone disease, and no obvious divisum. And the collection that we have, and what looks like a fatty liver, by the way. So the collection that we have is not something that you can intervene on. So we're going to just study the gallbladder to try and make sure we're not missing microlithiasis or sludge here. In the gallbladder, yeah, even in the gallbladder, right? Because the LFTs may be normal, but there may be stones or sludge here. So we're getting some air artifacts. I'm putting my balloon up. And you see there now, there may or may not be some floating like sludge right there. Because the question here is like for recurring acute pancreatitis in a young person, should you take out the gallbladder or not? Right there, I feel like there's some sludge. Some of this can be artifact too, but Some people sort of talk about palpating the gallbladder to see if things move around inside. I may sound like a radiologist, but I may say that microlithiasis cannot be completely excluded as a cause of pancreatitis. And the question becomes, should you then offer the patient a cholecystectomy or not? And there's debate on that in the literature. So let's have you try and do the second portion again. So I've reduced it for you, and all I want you to do is we found the papilla, a bit of big wheel towards you. I usually will be pointing this way in that corner of the room. Big wheel towards me, and then right away I'm on the pancreas, right? And from there, go clockwise, and then gently go counter, looking for the duct. And there you can see in the top right corner, you can see the pancreatic duct. So why don't you try that? Yeah, so big wheel, so point yourself more this way. Good. Relax this down. Big wheel towards you. Go, good. And keep it up. Big wheel keep towards you. And now go counter slowly. There you go. And you'll see the PD. There's your PD. See that? Now go clockwise. Don't let it fall. Don't let it fall. Go, yeah, but you're almost there. Good. There you go. So now we've kind of gone from the bulk, you've basically gone into semi-long position. So go reduce your scope again. Reduce the scope.
When we suck how to reduce balloon?
Push it down all the way. Push the section all the way down, and it should kick the balloon out. Okay, sure. Working it out. There. You have to push down really hard. Pull back. So reduce your scope. Reduce. Yeah, that's good. Big wheel towards you. Put the balloon up. And don't pull more. Okay, good. Now, that's enough. Now, that's your pancreas. You're going to go gently counterclockwise. Pull back. Go counter again. Don't pull too much, okay? Go counter. I just want you to find the PD. So go counter. There you go. Keep going counter. There's your pancreatic duct, right there. This here is the pancreatic duct. Go clockwise again. And you're following it towards the papilla. Go counter again. Good. And if you keep going counter, your bile duct will be up here. Careful. Yeah. Go the other way. When you lose it, you have to go back to track it down. Pull back the scope a bit. Pull back a tiny bit. And pull back. And now go counter again. There. And go. You may be falling, but that's okay. Keep going. There's your PD. And bile duct is up here, but it's getting compressed. Relax your big wheel, you may see it. Go clockwise again. There was a bit of bile duct, I think right there. That's okay, keep pulling back. And throw it mushkil. The balloon is very big right now. Relax the balloon section. And you just have to do this. It's not, आपका big wheel enough नहीं है. You have to do big wheel towards you, and then you do this and gently pull back. There's the PD and there's the bile duct. This is bile duct and that's pancreatic duct. Okay. Pull the scope back more, less big wheel, and now you can see the two. But the smaller the ducts, the harder they are to find. So take over from here, right where the PD is. Take over, big wheel towards you. Okay? Just for feel, and now go counter. Don't pull back, just go counter. PD, bile duct. See that? PD, and that's bile duct. And I'm not doing it from this. I'm actually doing it like this. This, and then this. वो थोड़ा सा practice की बात है. That's your PD, by the way, coming up now, right there. And you're going over the portal vein. So if you keep pulling back, now it's crossing the portal vein, and it's not division. ठीक है? So,
When we inflate the balloon, so in order to remove air, we have to suck.
yes.
So when we are taking the help of the balloon, touching the mucosa, when we will suck to keep mucosa intact with
That's
our
just
scope,
this much?
it will deflate the
No,
balloon.
because this much is air section, and I'll do it outside, and all the way down is balloon
Okay.
deflation. So there is slight difference.
Okay.
And just for in the room, this is the pancreatic sort of situation. You have the collection, a small pseudocyst type inflammatory collection, peripancreatic, extending here, and then the pancreas looks pretty inflamed. This is all hypoechoic. We made out the duct partially in here somewhere. I don't know if he has a little leak or if it's just bad pancreatitis with inflammation. Um, and you can see that the gastric wall is thickened in that area too from edema. So all this is all perigastric inflammation. एक दफ़ा मैं gallbladder और देखूं because I just want to make sure we don't miss anything in the gallbladder. Looks pretty clean. All this is artifact. ये कल वो बात कर रहे थे कि artifact, these rings are all artifact from the probe. This is not true sludge, so you have to be mindful not to call that sludge. This, on the other hand, I can't tell. But that too may just be ring artifact. Okay. Like, oh, mediastinum connect. So basically, if you want to quickly do that, you pull back.
Is GV junction or?
So basically, lymph node, like heart. So you come
Where
back.
we will keep here.
You just right above the G junction. So you see the heart, and if it basically you come back to this view, and you'll see left atrium on top. So left atrium, mitral valve, left ventricle, aortic valve, aorta, pulmonary artery. If you just pull back here a tiny bit and you spin around, you will look for lymph nodes. So this is a lymph node in level 7, subcarina. A tiny little, yeah, this is mediastinal lymph node. So this is level 7. And if you come back more, you will basically start seeing trachea here. So that's the trachea now. The rings from the trachea causing shadowing. If you keep going clockwise, you will get aorta. And now you'll see the aortic reflection. If you keep pulling back, you'll come to the arch of the aorta. And once you have the arch of the aorta in view, you will do big wheel towards you and go clockwise. And that'll typically show you pulmonary artery to the left, right there, and aorta to the right. And that's where you'll find lymph nodes as well. And then you can have branches of the aorta, which we don't necessarily need to take. Okay?
Thank you so much.
Thank you. No problem.